all the stuff, the Chantix, the nicotine patches, the nicotine gum, none of that will do it. They really, and so there's got to be a class that teaches cold turkey quitting.
What about those little fake cigarettes?
Yeah,
Is it really the
mechanical.
nicotine that's doing it though, or?
No, because the mechanical cigarettes are fine to use, and that's nicotine. Nicotine is what they're addicted to. Nicotine is what they're addicted to. Right, we think it's the tar. Yeah. So the other way I get people to quit smoking is never let. What does anybody see? Okay, so when you smoke, you like the cigarette. You like the taste of the cigarette.
I have smoked. Yeah.
So when you go to quit, they can never buy more than a pack at a time, so they can't buy a carton. And they can never buy the same brand twice. So you know there's 500 brands when you look at Walgreens or whatever.
I've got a husband I'm trying desperately to
So
get
if you-
to quit again.
If you
Desperately.
buy a different pack every day, they won't enjoy it. And so then you set a target, like you would say May 15th you're going to quit. And so between now and May 15th, it's a different pack every day, and then if they have the desire, then they will lose the taste and it will be easier to just stop.
So the alcoholics that smoke are really for congestive heart failure and aortic stenosis.
They're a mess.
So the alcoholism comes in causes like the congestive heart failure piece.
Right, but not always. You know, alcohol is a pretty good protection against the atherosclerosis. Not many alcoholics have MIs. Alcoholics who smoke have MIs, but not many alcoholics have MIs. The alcohol can be a direct toxin to the muscle of the heart and damage the pumping of the heart, but not usually by hardening of the arteries. So this is a picture of what we do when we bypass blood vessels. So you take veins out of your legs. You can't have varicose veins. They can't use varicose veins. Right. Pardon?
The one I thought it would be.
Yeah, they take the saphenous vein out. They plug it in an end-to-side anastomosis in the aortic arch, very close to where this left vein is. Can you see the left vein coming underneath that pulmonary artery? And then they plug it again down into this left anterior descending in an end-to-side anastomosis. Sometimes they do sequential grafts, so then they would take this graft onto this diagonal, right, with a long piece of vein. So they would go side to side and then end to side down here. And then this is one going over to the right coronary artery. You don't want to get to this point. So again, just a depiction of atherosclerosis with a clot on top of it, occluding the blood vessel. This is atherosclerosis pinching it to a 99% lesion, which is what our girl had yesterday. And this is spasm. We don't see a whole lot of spasm anymore. Spasm's a hard thing to diagnose. Spasm was in big favor in the 1980s. We can still artificially produce spasm when we put catheters in a blood vessel. And then it will just go like this. And nitroglycerin will relieve it. Verapamil intravenously will relieve it. So so here's, I don't know, I have these pictures. So here's a picture of a narrowed blood vessel. We don't really use the rotational atherectomy anymore, but we used to think if you could go in there just like a drill and just drill it out. But then it spreads downstream. So you have all these little microvessels. And then this is the balloon. Now this shows plaque on both sides. But if this side didn't have plaque, you would be exerting as much force on this side as you are on this side, and you can tear that. And so then here's reticulated chicken wire, that's the stent. And then this wall will actually grow around that stent, and you won't see those struts. So I'm going to show you pictures of the intravascular ultrasounds that we use. Again, these are stents placed. This is the balloon inside the stent. And then this is a stent in its final position. So when muscle, the heart muscle is an entire electrical system. Every muscle cell in the heart can initiate an electrical signal, very different than the muscles in the rest of your body. So when you starve the heart, okay, from a plaque, and it's suffering, it's not getting enough oxygen, and then you all of a sudden give it blood, it can get very irritable. And so you can have, ventricular tachycardia. We often see ventricular tachycardia in VF in the cath lab.
How far after
It
the
should-
cath
it's-
would you
It's usually only in the cath lab. And then with reperfusion, if you had a patient flown in from another hospital and they had TMK, you can get reperfusion arrhythmias for up to 12, 24 hours.
patient the other day had a stent and this had like a 8 centimeter, 3-4 feet of just in one lead and none for the rest of the night. And I just was wondering if that.
Oh, people who have but coronary disease is associated with ventricular arrhythmias. And there's a lot of things you guys find by doing telemetric monitoring that patients never know they have. So, he could have had those 3 little beats. Yeah, and you just don't know. They've done Holter monitors and they picked on medical students to look at how many PVCs are in a normal population, and it's a bell-shaped curve. And so you have outliers where you just have thousands of PVCs in a perfectly normal person. You have an average number, we all have PVCs, we all have APCs, and then you have some who have none. So that could have just been him with beta blockers. So the ultrasounds are what we use in the cath lab. And so it's a way we get to look at the inside of these blood vessels, and we're using them to position the stents to make sure that the stents are well healed. So when we look at an angiogram, we're just putting dye down. We're looking at a silhouette. So if you look at it, this is going to try to depict something else, but if you look at it, this one looks tighter than this one. Is this one tighter than that one? So that's where the ultrasound will come in. Oh, so I love this little cartoon. What you see is not always what you get. You see those, they're sitting on stools. So the ultrasound is sending out sound waves that are bouncing back and reflecting back to a transducer, just like an echocardiogram. They're going to look at walls. They're going to look at composition of plaque. And this is what it looks like. So this is the ultrasound. This is the intravascular ultrasound here. And this is all plaque. So they're showing you that they're looking at that lead, and that doesn't even look plaqued right there, does it?
No.
But you see all the plaque on the inside. Yeah. It's really added to our ability to treat disease. So this was just looking at who had an eccentric lesion versus a concentric lesion. So you see that this looks concentric, right? And this looks eccentric. Off. Yeah, but when we get inside, who's got the eccentric and who's got the concentric? This is concentric plaque, and this is all pushed down up here. So what we see is not always what we get.
How does that perform?
It's a catheter. It's an ultrasound catheter.
So you go right into the vessel.
You go right down the blood vessel.
Okay.
So I wanted you to, I really want, when your patient comes back from the cath lab and they said they had an intravascular ultrasound, sometimes it's one of the ones we use is a volcano, I want you to know what they did. And so this is going to look at the stent, so the stent is in here. You want to make sure that I have to look at this. Oh well, so do you see the struts of the stents here? Okay, so you want those to be appositioned up against their
So that was too
circumference.
small essentially, right? Okay, all right.
It's not expanded,
Okay,
not too small, not expanded.
got it. Okay.
And then here you can see the tear in the wall. And this is what stents were first designed to fix, because they sealed that right back up. I don't know what this is. Oh, the volcano. This is just one of, this is just a intravascular ultrasound. So what the volcano does is allow us to look at the composition of the plaque by color. So it just kind of will tell us whether there's fibrofatty disease, whether there's a necrotic core, whether there's calcium, this white stuff inside. So it just helps us as we put stents in. So I guess this is showing you this stent that's going through the stent. And so this is just grayscale and that's colors. That's actually a vessel on end. This is what it looks like when you're looking at it, and that's what it looks like if you had it post-mortem. Oh, and the volcano will better delineate it than just this grayscale. You see all this necrotic core in it. And so it's just a better way to look at it. Any questions? I didn't really get into the medicines. You can see black inside an open blood vessel. And we're just trying to get better at imaging what's really happening. And so, I just think that we ought to have another class and talk specifically about the 2,3-DA inhibitors and why you're using them and what they do to this and that sort of thing.
Do they find, like, this patient the other day, he's with chronic hypoxic, like severe COPD, and I bolused him because he was hypertensive, and then he just got like severely more short of breath, and and he had edematous in his legs, and I went to Dr. Carson, and I was like, he's just not tolerating the bolus wide open. Well, he has no history of congestive heart failure, so just do it. Like, does that create injury to like chronic hypoxia, obviously to the cardiac muscle?
Right, and so you would, I'm not criticizing in any way, I'm just saying that is very good critical thinking, that something's happening, I'm doing an intervention, it's causing these symptoms. So I don't know that he has heart failure, but should I look and see if he has heart failure? That's where you can measure a BNP. You can do one of those echoes. And you can look to make sure that you're not doing it. Because fluid in somebody who just has COPD should not make them short of breath.
Yeah, because he was just sitting this night and just like it was just completely just from the bolus when I started. I was like, I'm just having a really difficult time breathing, and he was just swollen. Pretty edematous.